So good morning, everybody, and welcome to our academic rounds at the Brunswick Heart Center. And it's my pleasure today to, we've invited a guest speaker from Halifax, congenital heart surgeon, Dr. David Horne, who's going to tell us on anomalous pulmonary veins, and the warden will get you out of jail. And it's really a follow-up conversation that I had with him recently on anomalous pulmonary vein patients that we see periodically. In terms of how to best address them from a surgical point of view. With that, I'll pass it on to you, David.
Thanks, Jeff. And you can see my screen with the title there?
Yes, it's perfect.
Perfect. So anomalous veins occurs in about 1 in 1,500 live births. So it does cross our paths every now and then, even as adult surgeons. And I'm going to start with 2 cases. And the first case is one that I get called for every now and then from here in at the QE2. So this is a 73-year-old male that's going in for CABG with Zlatko. The TTE shows he's got a dilated RA and RV, normal LV function and anterolateral hypokinesia, small PFO. He had a pre-op CTA for chest, which said there's no calcification. But there, as the sternotomy is performed, the radiologist calls in and says, you know what? The radiology resident missed the anomalous left upper pulmonary vein draining into the innominate vein. So how much swearing is going on in Zlatko's OR right now? So I'll move to another case before. Sorry, here's the imaging. So here you can see the vertical vein here. Zlatko says a lot. Yeah, so from the left upper lobe draining into this vertical vein, which is the equivalent of Marshall's ligament. Or a left SVC, but it just has a different name in this anatomy, going into the nominate and down into the SVC. So before I go into how to address that case, I give you another case here of a 38-year-old female that goes for a regular checkup. ECG shows some right axis deviation, a little bit of RVH. X-ray shows mild cardiomegaly. Gets sent to cardiology, and echo shows a little bit of right atrial and right ventricular enlargement. RVSP is still normal. No shunts are seen. And as any good cardiologist would do, say, well, something must be wrong. I'm missing something. Does an MRI. Confirms the right-sided enlargement. And it confirms there's an anomalous right upper pulmonary vein draining into the SVC, but no ASD. And the QPQS ratio, fortunately, they did that, is 1.35 to 1. These 2 presentations are for these less benign or less severe cases of anomalous veins, quite the common presentations, going for a physical checkup or incidental findings, usually not symptomatic. So this is her MRI. So you can see the SVC draining into the right atrium, and you can see this big vein coming in from the upper and middle lobe. Which people sometimes would think is an azygos, but an azygos, remember, is above the pulmonary artery, more in line with where the arrowhead is, giving you the clue. And so this one is not right at the right atrial SVC junction, and that's the variation that can occur. This for the right upper anomalous pulmonary vein can occur anywhere from the junction, anywhere all the way up to the innominate vein itself. So now what? So 2020, the American Heart Association published adult congenital guidelines on basically all adult congenital heart disease that we would encounter. But it was the first one since 2009 of the Canadian guidelines to specifically address anomalous veins. In the past, guidelines would just say, well, treat it the same as an ASD because the physiology is the same. So what does it say? So basically it says surgical repair is recommended for patients with partial anomalous veins, with functional capacity, when functional capacity is impaired, RV enlargement is present from the volume, and there's a net left to right shunt sufficiently large to cause physiological sequelae, i.e. the QPQS ratio more than 1.5 to 1, ensuring that the PA systolic pressure is less than 50%, so that there's no pulmonary hypertension, so no Eisenmenger physiology. Or if you're going in for repair of a sinus venosus ASD, which will also, it's an ASD, the physiology and the criteria is the same, is more than 1.5 to 1 low PA pressures. So 1.5 to 1 is the number to remember. So Zlatko calls me and he asks me what I should do. And I say, well, you got to do a shunt ratio intraoperatively. And Zlatko is like, okay, how do I do that? So for the surgeons in the case, how would you do the QPQS ratio? Where would you take your samples in this case? This is for case number 1. The left upper anomalous pulmonary vein draining into the innominate vein.
SVC and right atrium?
SVC and right atrium.
Or sorry, right internal jugular and right atrium is what I meant.
So right internal jugular. Okay. Any other takers for where else you should take samples?
I can't Google fast enough.
So as a reminder for the surgeons, I know the interventionists know the QPQS ratio is your aortic sat on your mixed venous sat over your LA sat minus your PA sat. So with that in mind, so where would you take your samples now? Zlatko, any ideas?
Yeah, sorry, I just got to think this through myself here, to be honest. Give us a hint.
I gave you the hint. I gave you the formula. Anyway, so you need an aortic sat. So luckily you've got an arc line. So your arc line, you don't have to go poke the aorta. You've got an arc line that gives you, and as long as if it's 100, it's easy. That's the same as your LA. Your MPA sat, just do a little purse string on the MPA, stick a needle in there, get a sample. But now here's the trick. You should not be doing a right atrial sample because the RA, the SVC, the innominate, and the vertical vein all have oxygenated blood. So it is contaminated and will give you a false low QPQS ratio. And most of our patients have a right IJ, and if the tip is anywhere in this junction, you will contaminate with oxygenated blood from that innominate vein. So where you need to take it is down here at the IVC. So put a little purse string like you would for bicable cannulation. Use that as your mixed venous. It's not the true mixed venous, but it is a good enough surrogate to tell you the degree of the step up in your QPS ratio. So you do that and you get a ratio of 1.2 to 1. And I tell Zlatko, just finish your cabbage, leave the anomalous vein, and don't use the central line post-op for mixed venous sats because it's going to be false high. But if it's more than 1.5 to 1, then we'll have another conversation. I'll show you how to repair that in a second. So for case 2, so now this patient, she was 38 years old with a right upper anomalous pulmonary vein. And so she gets diagnosed with hypertension at 48. She gets put on an ACE inhibitor. Then she gains weight at 58. She starts getting short of breath. Stress test, she does about 8 meds. Non-diagnostic ST depression that recovers within a minute. Echo shows still some atrial and ventricular enlargement. Normal RV-LV function, RVSP is only 28, still basically normal. Undergoes a cath and shows normal coronarings. They do a QPQS ratio and they get 1.2 to 1. I remember the previous MRI said 1.35 to 1. The RA sat and the PA sat is there is 83 and 85. So this is now for the cath guys on the call. Can you believe these numbers? And what would you do with the patient now? Any of your cath guys on?
Yeah, it's Colin Barry. It seems, the SATs are pretty high for RAPA, and it's so I'd be suspicious on that. So
Yeah, I
want
agree.
to do a full study for sure, and then normally when I do right heart cath, I'll do PA, RA, and aorta, and that's generally my kind of standard approach, unless it's someone we suspect is a congenital disease or shunt, and then we'll kind of do, based on what the history is, kind of and then do a kind of more of a full study, IVC, RV, RA, PA, both sides, SVC.
Yeah,
Okay.
and in this case, obviously sample before you think it's mixed. So
yeah, and that's the big thing here. So if you take the RA, there's already mixing, and so if you actually go into the nominate vein, go higher up. So this was a right upper into the SVC, so go above that level. You actually get an innominate SAT of 72, and your QPQS ratio is 1.85 to 1. And so that's a common thing that I see clinically, that we get caths and they would discuss the patients, and then where did you take the sample? And then the patients have to go back for a second cath. So knowing the anatomy before and just adjusting to that. So, and then you can just do your FLAM formula for innominate and IVC to get your mixed venous number.
So David, as a practice, wouldn't it be sort of appropriate then to always, when you insert, for example, if you go IJ or femoral, not just do the peripheral from the poke at that time, I guess, at that site as a way, as your routine, as part of everything?
So you know, I think your catheter guys will agree here. If you take it from your femoral vein right where you are, then the abdominal organs haven't extracted the oxygen, so
it won't be helpful. It won't be helpful.
Yeah, it won't be as accurate. Yeah, so
Okay.
you need to be a little higher.
Yeah.
And sometimes you can. So like if I have an inferior inferior sinus venosus ASD, like Mr. RC that we share. You know, so if you're too close to the RA in the IVC, you can still get contamination there. So you got to be a little lower, because even if there's an eustachian valve in the IVC, it's not always fully competent. Yes. So it's important to know the anatomy and be a little bit away to get your true numbers. Yeah. And if you're not sure, then get an MRI. Then just do flows. What we usually end up doing.
And in terms of the accuracy with MRI, they then be better, obviously.
Yeah, the accuracy will be better because they measure flow at the PA and the aorta. So it depends on how good your MRI acquisition is and how comfortable your team is with getting those numbers. But the technology today is pretty good. It's not like an RV where there's a lot of trabeculations and there's a lot of interpersonal variation on your analysis there. So any other questions on the diagnostics?
Nope.
All right, so PAPVD, so there's 4 main types. And interestingly enough, the different types correlate with where they come from. And the reason for that is just embryologically, there's a principle in vascular formation that no 2 arteries will cross each other, one running over the other. They will actually fuse and be branches of each other. And the same is true for veins. It's only the systemic and pulmonary veins that will cross over each other in and around the heart. But when there's an anomaly with the pulmonary veins connecting to the pulmonary bud from the left atrium, that's when the pulmonary vein says, okay, what's the closest thing I can get to drain? So then it makes sense that for your right upper lobe, you get drainage to the right atrium or right SVC. Your right middle and lower lobe will go to the IVC, so that's your scimitar syndrome. Type C here, the left upper and sometimes middle segments will then go to the vertical vein, innominate vein, because the left SVC or the superior cardinal vein is the closest structure. And your left lower vein will just go straight into the coronary sinus. So those are the 4 different partial anomalous veins. And so partial anomalous veins, furthermore, it's important to realize if you have 1, you might have 2, because the definition of partial anomalous veins is less than 4 veins drain to the LA. So 1 to 3 veins that drain anomalously. But most commonly, there's just 1 at a time. Obviously, the most common association that you want to know about is an ASD, but as I presented to you, case 2 is an anomalous right upper pulmonary vein without a sinus venosus ASD. But you can see on the sketch here, like the scimitar, and I did one of these a few months ago, doesn't have an ASD, that you actually have to create an ASD in your baffling. And the left innominate can have a small ASD or a PFO, and then the coronary sinus one, there's usually an ASD as well. So you got to go look and know what the anatomy is intracardiac as well. So repairing the case 1, if you did have to repair it, is actually pretty simple. You just have to ligate that vertical vein and then use the left atrial appendage and flip it backwards and put that on the vertical vein and just do a side to side, or you can have a filleted into side anastomosis. The pitfalls here is that the left phrenic vein, because this is like in left SVC, and what is lateral to the right SVC is a phrenic nerve. So the phrenic nerve can get injured in your dissection and freeing this up. So be aware of that. And because it's venous structures, they're low pressures. So 2 low pressure systems on each other, they can very easily kink. They don't have pressure to force them open to keep the lumen open. So you're bringing the vertical vein from a vertical position down to a horizontal position. So it's important not to rotate the vein and cause twisting and kinking in the process. But otherwise, it's just a simple, straightforward anastomosis that any cardiac surgeon can do, in my opinion. For case 2, so this is the inside of the right atrium. So for the non-surgeons here, this is a surgical view. So on the left of the picture, it would be the head. On the right would be the feet. So this would be the SVC coming in here, and there's the lumen of the SVC. These are the anomalous pulmonary veins draining close to the sinus venosus ASD. Here's your oval fossa in the right atrium, your drainage of your coronary sinus. into Cox triangle, and this is your IVC opening on the right. So this repair is pretty easy. It's just take a autologous pericardial patch, they close together, and just sew the patch, nice bulky patch over all the holes. What happens in the process is basically at the bottom here, you can see the anomalous veins just drain into underneath that patch and then into the LA, and then the SVC blood drains over. But with any of these repairs, there's three things that can go wrong. So number one, you can see that the atriotomy is quite high, so the SA node's at risk. Depending on the anatomy, and I'll show you some other anatomy variations now, you can narrow the SVC or the systemic venous return, but you can also, if these veins are further apart, which I'll show you, you can narrow the pulmonary venous return. So if you have veins that join right at the RA-SVC junction, that's the easiest one to repair with a single patch. So those are the three complications we want to avoid. So the sinus node anatomy, I think it's consistent. By textbooks, I think I can always see it. It's the fatty tissue at the base of the SVC-RA junction, right on the top of the sulcus terminalis. There's always fat there, so just avoid it at all costs. But the problem is, where's the vasculature going to that SA node? And sometimes we're injured when we do transeptal approaches to the left atrium, but here you can see the variations. Either it comes through the aorta and the SVC, or around the SVC, or a double supply, which is great. Then you can cut one, you still have supply to the other side. So it's not just direct injury to the SA node, but also the vasculature to the SA nodes that can get injured. But interesting enough, if the vasculature is injured, the SA node will probably still start working in the future. So if you have SA dysfunction from vascular reasons, just wait, and you might not need a pacemaker. But it's important in the next repairs that I look at, that we're going to show you. So you see up in the block here, that was the easy repair. The veins are close together. But now in the bigger picture, you can see that the two circles are apart. You can't overlap them. So to just sew a patch to try and get these veins, the pulmonary anomalous veins, through the SVC to this ASD. And it's even more difficult if you don't have a sinus venosus and you have to get to the oval fossa. It's a very long baffle that you have to reconstruct within the SVC. And now you're at risk of really obstructing the systemic and the pulmonary venous return. So the repair for that is actually incising the right atriotomy up the lateral side of the SVC. And there's actually a vestibule because of the extra blood from the anomalous veins. But there's a vestibule that you can incise in, but you got to stay behind the sulcus terminalis. So between Sondergaard's groove and the sulcus terminalis is where this incision is. So you can avoid the SA node sitting on top of the sulcus terminalis. And then it's a much longer patch that needs to get sewed to make this baffle into the left atrium. And if you would just primarily then close the right atrium over them, then you'll get systemic vein obstruction. So you need to have another patch to close that defect as well. So that's called the two-patch repair technique when the veins are still pretty close. And the rule of thumb that I use is that if you look at the pulmonary artery that you're imaging, if it's more than the superior half of the pulmonary artery up away from the atrium, this repair will actually not help you. So it has to be pulmonary artery and less. So the first repair is right at the junction. Pulmonary artery and less, you could still get away with this. But higher than that, then you're going to start risking, all three of those complications. Other thing to remember as well is to know where the azygous vein is, because if you include the azygous vein in this closure, because usually the three of them sit very close together. In this picture, it's quite likely that this upper vein might be the actual azygous. So it's important to actually look on the other side of the pleura to make sure you have red blood in that vessel, that you don't cause a right to left shunt and have desaturation. So what's the Horne procedure? The Horne procedure avoids all those complications. So it's a translocation of the SVC to the right atrium, and then the distal SVC stump becomes your baffle for the pulmonary veins to the left atrium. I'll show you what that looks like. So firstly, it's a very high bicaval cannulation. I actually cannulate in the innominate vein, and I use a plastic curved cannula, and I use an eye cautery, and I'll make a hole at the back so it drains both sides better. Sorry, and then you try and transect above the pulmonary veins, making sure that the azygous is ligated, because you want mobility on this section to move to the right atrium. You can see a patch being sewed in over this dome. And you can see now the pulmonary vein is going to go from here into the SVC, and will on the inside going to channel this SVC to the left atrium. So here you can see the dome is now covered. The right atrial appendage is then opened up, and pectinate muscles are transected, because it actually then allows the right atrial appendage to stretch to try and get to that SVC. So here you can see from the ASD that was behind this patch, it's just closed right to the SVC. So the SVC opening now becomes your channel that you're baffling. And with this, the risk of pulmonary venous obstruction is just about zero. The only risk here is that these upper sutures here on the left are right underneath the SA node, and needs a lot of thin, long bites to not injure the SA node from within. And then here you can see the reanastomosis of the SVC to the right atrial appendage. The only pitfall there is the rotation of the appendage, that you can actually cause torsion and cause narrowing. But it's an easy fix. Just don't close the whole thing and put a big patch anteriorly. Then you don't have to be as precise in the procedure. So this is what it looks like intraoperatively, just from within. So picture A. So there's the SVC opening there. That's why there's a little bit of blood in there. This ASD had to be enlarged. That's why you see the sutures on the rims. The bovine pericardial patch is now sewed into that area, and this is the area where the SA node will be. And then from the outside, so C is usually in children that we can easily mobilize enough to get a direct anastomosis. And in order to do that, I also ligate and divide the right internal mammary vein, and then free up the whole both innominate veins to get things to pull down. And this one was done without an anterior patch. But in adults, usually you need a bit of an interposition graft if you can't make it work to get them together. And so that's the Warden. So this way you have no obstruction in the back baffle and no obstruction in your systemic baffle. And if you did your patch nice and shallow here, you'll have no SA node injury. If need be, if you did have an injury with the Warden, you could still do a transvenous pacemaker. But if you have a narrowing or a borderline systemic venous baffle with your 1 or 2 patch technique, then adding endovascular pacing lead, then you're going to narrow your systemic baffle even more, and you're going to go back with issues. So then you need to use an epicardial pacing system. So what I look for after the repair is that the SVC has a mean gradient less than 2, and clinically post-op follow that there's no SVC syndrome features, and that they're on X-ray. There's no regional lobar congestion. I leave them on aspirin for at least 6 months, just while the autologous patch gets endothelialized, and then do a CT or MRI 1 to 2 years post-op to look at both baffles. And usually if that's fine, if it's good at that stage for adults, you don't need to check anything again. Yeah, so that's the Warden, gets you out of jail. I'll take any questions.
Perfect, David. All right, if you can stop sharing your screen there. You know, it's one of those things that I've certainly called you on a few occasions regarding congenital problem. So this is a good opportunity for all the cardiologists who are on the call here. There's certainly some guys from Moncton that I've spoken to in the last few months that we referred back to you here in Halifax for adult congenital issues. They do come up, and they do. Yeah. You know, of the most common adult congenital, not just regarding anomalous pulmonary vein, what is the sort of more common things that you think you would like to see that you may not see, or that, you know, sometimes get delayed for some reason? What are the...
So the most common lesions, number one is bicuspid. So we all deal with bicuspid aortic valves. And so coarctations in today's day and age get dealt in the early infancy because of, especially in Canada, being first world and good follow-up. So if those patients come back, if they have recoarctation, the treatment for that is called balloon dilation with a stent, a covered stent if need be. And that can be treated locally, like when you do any of your aortic stuff. So Zlatko can deal with that. The next most common congenital anomaly is VSDs for us. And so they also get presented in childhood. So really the most common thing for us is, now that we're about 30, 40 years out from tetralogy repairs, is pulmonary valve replacements in patients with free PR. Because they can go anywhere from the 2nd to 4th, 5th decade before needing a pulmonary valve replacement. So that is the most common adult congenital surgery. But the weird and wonderful would be, the next common would be these anomalous single anomalous veins, but they're actually behind anomalous right subclavian artery.
Okay, very interesting. It's interesting. We had a couple of cortation.
That's the very common finding, which is usually benign. But periodically, they can actually be a problem and cause compression. Usually, what we'll see is when you do a TEE intra-op, is that you lose your right arc line. Again, there's nothing to do if there's no dysphagia, or if you have, the other problem with them is if you have trach patients getting tracheo aortic fistulas.
Yeah.
Yeah, and that's the one you don't want to see.
Yeah, it's interesting. We had a few TAVIs in the past week with coarctation at the same time. So, I mean, the quarks weren't that bad, but these were sort of a bit unusual, and we had to sort of negotiate a few issues. So they do occur.
Yes. Yes.
So with this, we're going to close for today. Thank you very much again, David, for taking your time to present to us, and thank you everybody for attending. And this session has been recorded for those of, and it will be posted on our YouTube channel. Anyways, David, you have a good day. Good day,
Thanks,
everybody.
Good day.
Thank you.
Thanks, David. Well done.